Hi all, am I audible? Please put in the comment box whether I'm audible or not. Yes. Am I audible? Yes. Good evening, Suganti. Sugant. Yes, yes, yes. So, hi everyone. I welcome you all to the important series of pharmacology, that is the clinical based MCQ discussion. This video is completely for the Plan C English subscribers, and this video is going to be completely in English language, right? So here we are going to discuss some of the most important pharmacology related MCQs. Along with that, what are all the most probable questions which is asked in that particular topic also we are going to discuss. So let's discuss the first question, and I want everyone to actively answer so that we will test your knowledge in pharmacology. So pharmacology direct questions may come on drug of choice and the important nursing implications, nursing priority action, what is the toxic level. So these kind of generalized questions may come. Like you will not get questions so deep in pharmacology. Mostly the questions will be integrated with your adult health nursing and other subjects, right? So very good evening, Bhavana. Very good evening, Hitesh. Hi, hello to everyone. So let's get into the session. The first question for you all. Yes. Now actively and quickly answer me. The patient diagnosed with acquired immunodeficiency syndrome is undergoing treatment that includes a protease inhibitor. Which common side effects should the nurse anticipate when evaluating a patient's response to this medication? Yes. I'm waiting for your answers. Now, you people have to answer me. A patient with acquired immunodeficiency syndrome is undergoing a treatment that includes a protease inhibitor. What common side effects should the nurse anticipate when evaluating a patient's response to this medication? Yes. Very good, Bhavana. Bhavana has given a very correct answer. So, what is protease inhibitors? These drugs come under your antiretroviral therapy. As you all know, these drugs comes under your antiretroviral therapy. Specifically, what drugs are coming? That is your lopinavir and your ritonavir, right? And your ritonavir. So to be very specific, the drug is the combination as used as your LPV and R, right? LPV and R, where your lopinavir is going to be 90% and your 10% your ritonavir is going to be presented. Right. So these drugs commonly causes the signs and symptoms of hyperglycemia. So we are directly rejecting it is not hypoglycemia. Tingling sensation in the extremities is not specifically caused by these drugs, and visual disturbance such as yellow halos around the light. Now tell me in the chat box like which particular drug causes this particular symptom of visual disturbance such as yellow halos around lights. Which drug is responsible for this? Yes, answer in the chat box. So see, you people are preparing for competitive examinations. This is a very common signs and symptom of a very, very important drug. I want you to answer like what specific drug has the serious side effect when it is reaching its toxicity level. Very good. So digoxin is a one drug which is going to cause this particular side effect. It is not your protease inhibitor. And to be very specific, what is the therapeutic level of your digoxin, and when we are telling it is a toxic level. So first is the therapeutic level of your digoxin is 1.5 to 0.9 ng per ml, right? This is the therapeutic level of your digoxin. Like when we are telling this digoxin is toxic, obviously when it is going more than 0.9 ng per ml, we are telling it is a toxicity. It is a toxicity. And to be very specific, at what rate, if the level is going to be higher, it is going to cause serious form of atrial fibrillation. When digoxin level is going greater than 1.2 ng per ml, greater than your toxicity level, it is going to increase the mortality and increase the risk of causing atrial fibrillation. Increase the risk of causing atrial fibrillation, as you all know. Then, if the level is going more than 2, it is ultimately toxic. If it is going more than 1.9 also, we are stating that it is reaching the level of toxicity where there is an effect and there is a risk for toxicity. But specifically, when the level is greater than 2, we are classically conditioning this is a toxicity. Right? Be very clear in this value because this is very commonly asked in your examination. What you have to remember is your normal therapeutic level of your digoxin is 0.5 to 0.9 ng per ml. When it is going greater than 0.9 ng per real, greater than 9 ng per real, we are stating that it is going for toxic. There is highest risk of toxicity when it is going for greater than 0.9 ng per ml. When it is going greater than 1.2 ng per ml, we are indicating there is a high risk of going for atrial fibrillation. When we are absolutely telling it is toxicity, when it is going greater than 2 ng per ml, we are telling it is highly toxic, right? So we'll go to the next question. So a 35 years old male patient was prescribed a drug from the treatment of gastroenteritis, for the treatment of gastroenteritis. However, he complains of severe restlessness, palpitation, and facial flushing and sweating whenever he takes alcohol after his medication. What was the drug prescribed to him? Now you people have to tell me. A patient who has done with the treatment of gastroenteritis, the pharmacological treatment was given to that particular patient, and he complains of severe restlessness, palpitation, facial flushing, and sweating whenever he takes alcohol after the ingestion of this medication. So now tell me classically, what is the correct answer? Yes. Omeshwari, please give a big round of applause to Omeshwari. Yes. When the patient is taking metronidazole, this metronidazole is having a property of causing disulfiram-like reaction. Disulfiram-like reaction. So whenever the patient is taking an alcohol, this is going to cause severe adverse effects such as your facial flushing, restlessness, palpitation, and sweating. Right? So it is very, very important to note. Now tell me, metronidazole is a broadly used drug. In what are all the cases it is used as a drug of choice? For example, if you take your giardiasis, as we have seen right now, and in case of your amoebiasis, in case of your trichomoniasis, in case of your bacterial vaginitis, in all these cases, your metronidazole is used as the drug of choice. In some other condition also, they are used, but you have to remember these things may be probably asked in your examination. So important side effect of your metronidazole is disulfiram-like reaction. Right? This is one of the important keyword you people have to remember. Whenever it is taken with alcohol, this is going to cause some aldehyde dehydrogenase reaction that is going to cause a severe form of side effects. Right? So let's go to the next question. Because a patient is taking rifampicin, what should the nurse include when discussing medication with the patient? right? So the patient is taking rifampicin. What advice I should classically give to that particular patient, right? So report any changes in hearing immediately because this is a common side effect. Now tell me which is there is any interaction of your rifampicin with hearing problem? No. You should be taking vitamin B6 to prevent painful neuritis. No, it is also not interacting with the thing. And if your big toes become painful and you must tell the physician, this is indicating the patient is having gout. All these statement was indicating some of the side effects of your anti-tubercular drug. Right? We will discuss in detail. So your perspiration and urine may turn red in color, like which means you're sweating, urine may turn red in color. Along with that, the tears will also become red orange in color. The answer is digoxin. The answer is D. That is, your perspiration and urine may turn into red orange color. This particular advice you have to give to the patient who is taking rifampicin, right? I'm sticking to the digoxin. Let me leave digoxin. Right. Now coming back to the anti-tubercular drugs, first is your isoniazid. So these particular drugs side effects are asked so commonly in your examination. So what are all the important side effects of isoniazid? Now tell me in the comment box, what are all the side effects of isoniazid? So isoniazid causes euphoria, interacting with your CNS symptoms, hallucination, and it also causes psychosis and neuropathy. Right. So these are all the very common side effects of your isoniazid. It also reduces heme. It also reduces heme. So thereby it is going to cause anemia as a side effect as well. So the primary component in exam point of view you have to remember is it majorly reduces your vitamin B6 level. It majorly reduces your vitamin B6 level. So what is the management which we have to do? Obviously, because of the reduction in vitamin B6 level, all these symptoms are happening. So obviously, the management will be what? Vitamin B6. Right? The management will be vitamin B6. When this particular isoniazid is going to the toxic level, it is going to the toxic level, right? Very, very important point to note. When it is going to the toxic level, it is going to cause severe form of seizures. It is going to cause severe form of seizures. At that time, what will be the management? So primarily, vitamin B6 is the management as we discussed. When the patient is going for toxic level, it is going to cause serious seizures. At that time, what is the management? The management is going to be IV vitamin B6. That is your pyridoxine. That is your pyridoxine. So what is the MCQ point you have to again remember is for 1 gram of your like 1 gram of isoniazid, you're going to administer 1 gram of vitamin B6. Okay, vitamin B6. And maximal how much dose I can give if there is a question. Pyridoxine dosage, like the patient has went for isoniazid toxicity and he is exhibiting severe form of seizures. So what will I give? Like what is the maximal dose? Like I know that I have to give vitamin B6, but what is the maximal dose I have to give? The maximal dose that is recommended for the patient with isoniazid toxicity, the pyridoxine dosage is 5 grams is the maximal dosage which you can give. Along other than that, we should not give extra dosage because it is going to further cause some other signs and symptoms. So next drug is your rifampicin. Right. Rifampicin, as we have discussed, it is going to cause orange red secretions. Right. It is going to cause orange red secretion, a very, very important symptom. And the most important nursing advice or nursing health education you have to give is the patient should avoid contact lenses. The patient should avoid contact lenses because the contact lens color can also change because of this. The patient has to avoid contact lenses. Next, it also causes some respiratory symptoms. What kind of respiratory symptoms it is going to cause? It is going to cause flu-like symptoms. Okay, it is going to cause flu-like symptoms as well. Okay, it is going to cause flu-like symptoms as well. So if the patient is going to have flu-like symptoms also, we are going to continue the dosing, but we have a limitation in that. In which cases we are going to stop or withhold or permanently we are going to stop the drug rifampicin. If the patient is getting purpura, where the platelet level is going to be reduced, here what we are doing, here we are stopping the medication. We are literally stopping the medication if the patient is going for purpura and if the patient is exhibiting pulmonary syndrome symptoms. Pulmonary syndrome symptoms. So this is very, very important to note. The primary symptoms which is commonly tested in your examination, as you all know, it is your orange red secretions. So that is the primary advice which you're going to give to the patient, right? So you're going to give a nursing advice that you have to avoid contact lenses. And along with that, the patient may also show, remember R and remember respiratory symptoms. And in what all the cases, we will stop the medication. We will stop the medication when the patient is going for any form of purpura where the platelet level is so much reduced. At that time, we are going to stop rifampicin. Or if the patient is exhibiting pulmonary syndrome symptoms, at that time also, we are going to stop the medication, right? So next is your pyrazinamide. So what are all these side effects of pyrazinamide? The pyrazinamide is considered to be the most hepatotoxic drug. Among all the anti-tubercular drugs, the most killer drug and most hepatotoxic drug is your pyrazinamide. That is a very, very important point you have to note. And remember pyrazinamide, remember pyru. You remember a word pyru, which means uric acid level. It causes hyperuricemia. Right. Along with that, it also causes arthralgia. Because of excessive urea, which is accumulating in your joints, this is going to cause severe form of joint pains as well. But the most important point you have to remember about your pyrazinamide is it is the most hepatotoxic drug, right? At last, the most important drug we have is your ethambutol. So ethambutol, very, very easy to remember. Ethambutol E, you have to remember, and the problem is in the eye. It causes optic neuritis. As you all know, it causes optic neuritis. And it also causes red and green color blindness. So, if there is a question, specifically which color blindness will be very prominent, then your answer is going to be green when comparing to your red. So is that is very clear about your anti-tubercular drugs side effects? First is your isoniazid. Isoniazid primary side effect is it will be reducing the vitamin B6 level. So this reduction in the vitamin B6 level is going to cause euphoria, hallucination, psychosis, and neuropathy. Along with that, it also reduces the heme level, which is going to cause anemia in the patient. And what is the management? Obviously, vitamin B6. When isoniazid is going to the toxic level, it is going to have seizures. At that time, we are administering IV pyridoxine. That is your vitamin B6. The maximum amount which I have to administer is only 5 grams. That also you people have to remember. Next, when we talk about rifampicin, it causes orange red color secretions, and you're going to advise the patient that you should not wear any form of lens. And the patient may also have respiratory symptoms, and you're going to stop the drug rifampicin if the patient is exhibiting purpura or pulmonary syndrome. Pyrazinamide, remember, it is the most hepatotoxic drug, and it also causes gout, that is hyperuricemia and arthralgia as well. Ethambutol, you have to remember about the E, that is I, that is for optic neuritis, and it also causes red and green color blindness. There, green color will be very prominent, that you have to remember. Right. If you ask me, like after pyrazinamide is the is the most hepatotoxic drug. After pyrazinamide, isoniazid plays an important role in hepatotoxicity. Then after that, rifampicin. This order also you have to remember. The most is pyrazinamide, next is your isoniazid, third is your rifampicin. This also you have to remember. Now coming back to the question, report any changes in hearing immediately because it is a common side effect. This is a side effect of your streptomycin. So streptomycin is a severely ototoxic drug, as you all know. That's why it is shifted to the second line anti-tubercular drugs, right? That's why it is shifted to the second line anti-tubercular drugs. And you should be taking vitamin B6. This is in case of your isoniazid. We should take vitamin B6. Next, if your big toes become painful, and you must tell the physician. As I said you about arthralgia. Arthralgia is very common in your pyrazinamide. So now I hope this question is very, very easy for you people to solve. And the patient who is taking rifampicin, definitely you should remember the patient should avoid contact lenses. So next we will go to the next question. Your friend is planning a trip to the mountain, but is concerned because of her history of severe nausea and vomiting while traveling. If a friend is telling he feels severe nausea and vomiting while traveling anywhere, this is a case of motion sickness. This is a case of motion sickness. Now tell me what is the answer in the chat box. In motion sickness, what is the drug of choice? Is it asking about drug of choice or what the question is trying to tell? Be very clear. So if the friend is having severe nausea and vomiting while traveling anywhere, we are concluding the patient is having motion sickness. So which of the following drug would be least effective? They're not asking about which of the drug is most effective. They are asking about least effective, right? But before answering for least effective, now tell me what is the drug of choice for motion sickness? What is the drug of choice of motion sickness? Yes, very good, Bhavana. The drug of choice of motion sickness is your scopolamine. That drug of choice of your motion sickness is your scopolamine. And what is the method of administration of this drug? As you all know, it is administered in the transdermal patch. It is administered in transdermal patch. It is administered in transdermal patch. And you have to apply it the night before the travel. Okay, night before the travel. The application is night before the travel. And the reapplication, when we will do reapplication, the reapplication after 2 to 3 days. Very good. It's a transdermal patch that you people have to remember. What is another drug, oral drug, which is available? This is a primary drug of choice, a transdermal patch. What is the oral drug which is available for this motion sickness? Any answers? What is the oral drug which is available for this motion sickness? Any answers from your end? That is your promethazine. Promethazine is the oral drug which we are administering for the motion sickness. 1 hour before the travel, we are administering. 1 hour before the travel. Right? Now coming back to the students who have answered correctly. Right? So very good. Many students, Pinky, Ishika, Tanushri, Suman, Suganti, very good. Many people have given answer as ondansetron. Yes. Ondansetron is an anti-emetic drug, as you all know. This drug is primarily acting in order to reduce the nausea and vomiting. So here, the patient is telling that he will be having a sensation once I get this traveling. When I get into traveling, I'll be going into this. So what is the answer here? So ondansetron is the drug which is not effective in the management of your motion sickness. Other than that, scopolamine is a drug of choice, and your meclizine and your diphenhydramine, these are antihistamines. Right? So these drugs are also involved in the management of your motion sickness, but it is not a most effective drug, but the most effective drug which is given is your scopolamine. Right. So these drugs are all also this antihistamines. These are H1 antagonists, right? So these are also given in the management. Prophylactically, they are given in the management of motion sickness and in case of your other problems. But it is not a drug of choice, right? That you people have to remember. Yes. So what is the important side effect of your scopolamine? Now tell me. Yes. It is used in prevention. Very good. Your H1 antagonist or used in the prevention of your motion sickness. Very good, Sugan. Now tell me, what is the side effect of your scopolamine? Any answer for side effects? The side effects are it causes dry mouth. It causes dry mouth and it also causes sedation. And to be very clear, this meclizine, diphenhydramine, these are H1 antagonists, which is given in preventive management. These drug crosses the blood-brain barrier. These drug crosses the blood-brain barrier. So definitely this is going to cause, these are first generation, right? So these going to cause sedation effect as well. That's why this first generation H1 antagonist drug are not given or contraindicated in case of children, elderly, and drivers and pilots, right? Yes. So next we will go to the next question. A pregnant woman present to your OPD with severe constipation. After ruling out pathological cause, which of the following is the safest to prescribe? A pregnant woman with a condition of constipation. So which of the following is a safe drug? Since the woman is pregnant, it is very, very important. Like you should not administer any form of teratogenic drug or which is rapidly absorbing and crossing the placental barrier. So which particular drug in the given option? Yes, very good. Very good, Sugant. Very good, Shalini. The answer is lactulose. Yes, lactulose is one drug, one component which is not absorbed, right? And it is going to primarily act on the constipation and get an immediate relief. So it is an osmotic purgative, as you all know. It is an osmotic purgative. So it is very safe during pregnancy. So what about this? What about this Senna and your bisacodyl? Few words about your Senna and bisacodyl. These two drugs, okay, these Senna, bisacodyl, and your along with that we have another drug that is your Cascara, right? So these drugs come under the classification of increasing the intestinal contraction. It increases the intestinal contraction. So these drugs primarily act on the mechanism of increasing the intestinal contraction, and it also increases a low-grade inflammation and aiding in mobilizing the stool. The effect are always after 6 to 8 hours. As you all know, the effect of this drug is always 6 to 8 hours. That's why these drugs are administered in night. That's why they are preferred in night time only. What do you think about Docozet? Yes. Now tell me what you think about Docozets. Docozets are stool softeners. Right? These all are laxatives. Okay, these are not antidiarrheal drugs. This Senna, bisacodyl, Cascara, these are all laxatives, dear children. They are not antidiarrheal drugs. We will see about antidiarrheal drugs as well. So next we will go to the next question. A patient has been diagnosed with colon cancer and is scheduled for an abdominoperitoneal resection with colostomy. abdominoperineal resection with colostomy. The physician has prescribed neomycin before surgery. The nurse explains that the primary purpose of administering this medication is to. What is the primary purpose of administering this medication? Now answer me. Why we are administering for a patient of abdominoperineal resection? We are administering neomycin. What is the purpose of administering neomycin? Very good. See, neomycin is basically an antibacterial drug. As you all know, it is an antibacterial drug. Very good. So obviously, in order to do the reduction in the bacterial content in the colon, like for example, when the patient is going for this abdominoperineal resections, these patients are highly risk for increased infection because of the gut bacteria. So what we will do, we will administer antibiotics such as neomycin in order to do a gut sterilization. This process of administering a bacteria and clearing the gut, clearing the bacterial content in the colon is termed as your gut sterilization. Right. This gut sterilization is primarily done in order to prevent the post-operative infection. Yes, very good. Very good, Sugandh. In order to prevent post-operative infections. Post-operative infections. So to be very, very clear about these things. Decrease the peristalsis? No. These options, reduce the inflammation of the bowel? No, they are not anti-inflammatory. Helps to prevent post-operative pneumonia? No. It is completely for preventing the post-operative infection and for gut sterilization. This is very, very important to note. Next question. A patient with herpes zoster shingles is receiving treatment. Which medication is most likely to be administered? Now tell me, what is the drug of choice in this case? A very, very important and as well as a very common question. A patient is a case of herpes zoster shingles, which is a reactivation of your varicella zoster, as you all know. This is the reactivation. Yes, very good. Very good, very good, very good, very good, very good, Sugandh, very good, Bhupesh, very good, Shalini, very good, Suman, Sugandh again, Sanjita, Joy, Shazia, Cholet, Ishika, very good. So we will, very good. And an important thing, others or what? Others or antibiotic. This is antiviral. So obviously B is the correct answer. But we will also see reactivation of your varicella zoster, as I said you. So for what are the drug of choice we will see? For example, we have oral drug, that is your valacyclovir, as you all know. Oral valacyclovir we have. Okay. And we also have acyclovir. So these both drugs are used in the management of your herpes simplex virus as well as your varicella zoster virus. Varicella zoster virus. Now I'm telling, I will give topical acyclovir in case of local infection. In case of local infection. What if the patient is a case of HSV encephalitis? Now answer in the chat box. What is the drug of choice when the patient is a case of HSV encephalitis? If the patient is a case of HSV encephalitis, my drug of choice is IV acyclovir. Don't confuse yourself. IV acyclovir is a drug of choice if the patient is a case of HSV encephalitis. Right? And the most important drug, we also have cytomegalovirus retinitis. Cytomegalovirus retinitis. In that case, we have two drugs, that is your oral valganciclovir and ganciclovir, right? Oral valganciclovir and ganciclovir. So these drugs are used in cytomegalovirus retinitis, right? So this is very, very important to note. And If the patient is taking IV acyclovir, what is the side effect? Now tell me, what is the side effect? Right. Now tell me, if the patient is taking IV acyclovir, what is the side effect of IV acyclovir? IV acyclovir has an increased effect of causing crystalluria. And it increased the risk of renal failure. So proper RFT management, RFT maintenance has to be done to this patient. And if you talk about your ganicyclovir and valacyclovir, what is the important side effect? The important side effect you people have to remember is these patients will go for bone marrow suppression. These patients will go for bone marrow suppression. Right? So other drugs are distractors, so they are not the answer. So these are all the important exam pointers which you have to definitely remember. Right? So next, a patient has severe diarrhea and the healthcare provider prescribes intravenous fluids, sodium bicarbonate, and an antidiarrheal medication. Which commonly prescribed antidiarrheal drug should the nurse expect? Now tell me what is the answer. Here they are asking about antidiarrheal drugs. So fastly you have to answer me what is the antidiarrheal drug which will be recommended for this particular patient for severe diarrhea. What is the drug of choice? Very good. Your loperamide is the correct answer. Loperamide is a opioid drug which is administered for non-secretory diarrheas. Non-secretory diarrheas. Non-secretory diarrheas. Right. The most important thing you people have to remember is it is given in case of, this is a primary drug of choice if the patient is a non-secretory diarrhea, and it is an important drug of choice in the management of your irritable bowel syndrome. It is the management is very good. Diksha, very good. Very good Paulami, very good Sanjita, very good Shalini, very good Bhupesh, very good Sukant, Ishika, very good, very good, very good. So here you people have to remember this very clearly that in case of irritable bowel syndrome, this is a drug of choice, right? And if it is a case of secretory diarrhea, now tell me what is the drug of choice? Secretory diarrhea, the drug of choice is your octreotide. Okay, the drug of choice is your octreotide. In case of secretory diarrhea, the drug of choice is octreotide. This you have to remember. Right? Yes. So this bisacodyl, psyllium, and your docosahexaene sodium, these are constipation drugs, laxatives, right? So the next question. A nurse is reviewing the medical history of multiple patients at clinic who has prescribed rifampin for tuberculosis treatment. What patient requires special consideration? Again, this is a very, very important question. So I'm expecting these kind of questions where interaction-based questions. So now tell me, what is the answer? A nurse is reviewing the medical history of multiple patients at a clinic who are prescribed with rifampicin for tuberculosis. What patient requires special consideration? What is the interaction of rifampicin with the given scenarios? Yes, very good. For all who are answering B, now tell me in the comment box, what is the reason behind this? What is the reason behind this? Your rifampicin is a potent inducer, of some hepatic enzymes which will reduce the effectiveness of certain drugs. Specifically, when we talk about oral contraceptives, this particular drug is going to reduce the effect of that. How it is reducing the effect? It increases the metabolization. It increases the metabolization of the oral contraceptives, thereby reducing its potency, thereby reducing, yes, it is an enzyme inducer. It is a potent enzyme inducer, right? So can you tell me in advance, like what are all the specific enzymes which it is inducing rifampicin? Can you tell me in advance? Yes. So it increases the metabolization of OCP, thereby reducing its potency. Thereby reducing its potency. Now tell me, it is an enzyme inducer. What enzyme it is specifically inducing? It is inducing your cytochrome P450. Your cytochrome P450. Yes, any student is answering? What is the specific exam? Cytochrome P450, right? That is in hand, your CYP3A4. And along with that, your P-glycoprotein. P-glycoprotein. So these enzyme induces the metabolization of the other drugs, specifically the contraceptives, thereby reducing its efficacy. On the other hand, you people also have to remember, when this rifampicin is in interaction with the ART drugs, this also reduces the potency. They also have interaction with the antiretroviral drugs, and it is going to also reduce the potency of the antiretroviral drug. So in other cases, if they have given the situation like the patient is taking medications for HIV or AIDS, in that cases also, you should be very clear that it is having an interaction with ART drugs also. With ART drugs also, it reduces its efficacy, right? So next, we will go to the next question. Or else, on the other hand, we have, let me discuss about, we have talked about enzyme inducers, which is going to reduce the potency of the drug. What are enzyme inhibitors? Any example for enzyme inhibitors? You people can give me any example for enzyme inhibitors. So specifically remember your quinidine, isoniazid, protease inhibitors. These are all comes under enzyme inhibitor drugs. If it is inhibiting the enzyme, what will happen? This is going to increase the toxicity of the drug. It increases the absorption of the drug and it increases the toxicity of that. The best example, exam centrically, when if I want to give, I will tell erythromycin. Erythromycin, an enzyme inhibitory drug, can cause theophylline toxicity. Theophylline toxicity. Remember this. Erythromycin is an enzyme inhibitor drug, and this can cause theophylline toxicity. And let me give another example. Clarithromycin. Clarithromycin increases what toxicity? Very good, Sugant. Sugant is in full form preparation. Very nice. Yes. Now tell me, Sugant, actively. Clarithromycin will cause what toxicity? Clarithromycin will cause what toxicity? Clarithromycin can increase the risk of your statin toxicity. Very good, Sugant. Very good. Please give her a big round of applause. It can increase statin toxicity. Sugant, you have cleared prelims? Hopefully waiting for your mains examination. I think so. You have cleared your prelims and you are positively waiting for mains. All the very best for your mains, my dear children. Yes, Bhupesh. Yes. The next question, a patient with a history of tuberculosis reports difficulty in hearing. Which medication should the nurse suspect as the cause of the symptoms? A very, very easy question. Yes. Again, a very easy question. Streptomycin is having interaction with tuberculosis, with hearing difficulty, right? Yes, yes. Most welcome, dear. So streptomycin is having a very much interaction with your tuberculosis, with your hearing difficulty. So that will be the answer. Pyrazinamide, isoniazid, ethambutol, we have discussed very clearly. Like I would like to add from the previous question. If a patient is taking loop diuretics, okay, if a patient is taking, I'm talking about the previous question, a patient is taking loop diuretics. In which are all the cases loop diuretics is contraindicated? Loop diuretics is contraindicated with which drug? Yes. This is a very easy question. I'm asking you a question. Like loop diuretics is contraindicated with which drug? Active preparing students should immediately answer for this question. Loop diuretics is contraindicated with which drug specifically? Any answers? Please think about it. Let me talk about furosemide. Okay, furosemide is an important drug which is used as a drug of choice in case of your pulmonary edema. No one is answering my question. Okay, let me tell. Always remember, loop diuretics is contraindicated with your aminoglycosides. Aminoglycosides. Always remember this important point. Loop diuretics is contraindicated with your aminoglycosides because it can cause severe form of ototoxicity. Why? When you ask why, it causes severe ototoxicity. Okay, it causes severe ototoxicity. Again, an important MCQ you have to remember. Right? Yes. Other side effects is like generally loop diuretics can also have some side effects such as ototoxicity when it is given with aminoglycosides. What are the other side effects? Other side effects is your hypocalcemia. And it also reduces potassium. It can cause metabolic acidosis. Right. On the other hand, this loop diuretics increases. Now tell me in the answers, this loop diuretics on the other hand, this can increase uric acid level. Increases glucose. And again, coming back to the first line, it also decreases magnesium. It causes hypomagnesemia, very good, hypomagnesemia, hypokalemia, hypocalcemia, metabolic acidosis, and it also increases uric acid and increases glucose level. But you have to remember the important drug interaction. When it is administered with aminoglycosides, it is going to cause severe form of ototoxicity. That's why it is contraindicated. Right? So these loop diuretics, we have various classification. Now tell me, among the loop diuretics, which is the most potent loop diuretic? Answer me in the chat box, which is the most potent loop diuretic? If they're asking which is the most potent, which is the longest acting, what will be your answer? The most potent loop diuretic is your bumetanide, right? Your bumetanide. Your bumetanide is your most potent loop diuretic, right? And which is the longest acting loop diuretic? Longest acting. Now answer me. We will talk about thiazides also. See, I'm not talking about, I'm specifically asking a question. Among loop diuretics, which is the most commonly used, is furosemide. Furosemide is an important drug of choice in case of your pulmonary edema and in case of your renal insufficiency. This is very, very important and this is very common. I'm asking, among inside this loop diuretic classification, which is the most effective drug, most potent drug, that is your bumetanide. What is longest acting? The longest acting drug is your torsemide. Okay, remember it is your torsemide. The longest acting is torsemide. If they're going to ask you, which is the most ototoxic? Which is most ototoxic? Which is most ototoxic? Any answers? Which is most ototoxic among all? The most ototoxic is your ethacrinic acid. That is your ethacrinic acid. These all drugs are coming under the umbrella of loop diuretics. Always remember, these all drugs are coming under the umbrella of loop diuretics. Along with that, remember, these loop diuretics are very, very helpful when the patient's GFR, is less than 40. If the patient's GFR is less than 40, your loop diuretics is going to be very, very important. Right? Yes. Some people are talking about thiazides also, right? Thiazides are the drug of choice in hypertension with edema, nephrogenic diabetes insipidus, and other form of edema, right? Thiazides, loop diuretics, they're specifically acting on the ascending limb, as you all know, right? Ascending limb. Whereas your thiazide diuretics, they open up the calcium channel and that's how they work, right? So this is a drug of choice in case of various form of edema. First is patient with hypertension with edema, or if the patient is having nephrogenic diabetes insipidus, which is renal system oriented, nephrogenic diabetes insipidus, or any form of edema, the drug of choice is going to be thiazide. So what are all the drugs we have? We have chlorothalidone, we have indapamide, and at last we also have metalazone. So now answer me. Among this drug, which is the longest acting drug? The longest acting drug is your chlorothalidone. That is the longest acting drug among your thiazide diuretics. Thank you so much, dear. So chlorothalidone is the longest acting drug among your thiazide diuretics, right? See, the side effects of your loop diuretics and thiazide diuretics will be more similar. Specifically, when we talk about the side effects such as your side effects of your thiazide diuretics, similar with your loop diuretics. For example, it also causes reduction in potassium. It also causes metabolic alkalosis. See, remember, this is not metabolic acidosis, this is metabolic alkalosis. Please, sorry for the confusion. Remember, this is not metabolic acidosis. This is metabolic alkalosis. Loop diuretic causes metabolic alkalosis. Don't remember it as acidosis, right? Coming back again in thiazide diuretics also, you can see metabolic alkalosis. And along with that, it will increase the uric acid, as I said uric acid level, glucose level. Glucose level, it is also going to increase, and it is also going to cause decline in magnesium. These are similar symptoms between your loop diuretics and thiazide diuretics. Now, I'm going to tell you what are all the additional side effects which are very, very specific to thiazide, right? Additional side effects which is specific to thiazide is this drug. We have seen previously loop diuretics is going to cause hypocalcemia, but here thiazide diuretics causes hypercalcemia. Remember, it causes hypercalcemia. Thiazide diuretics causes hypercalcemia. And this drug is contraindicated in case of your hypertension with DM or gout? Obviously, it is increasing the uric acid level. So it is increasing the glucose level. So definitely it is contraindicated in case of your DM and gout. Right? These are all the additional points you people have to remember before going for your examination. Right? So next we will go to the next question. Yes. Now come on, tell me the answers. Which of the following drug get deposits in cornea? Which of the following drug gets deposit in the cornea? Yes. Which of the following drugs gets deposit in the cornea? Answers, please. Which of the following drug? Very good. Chloroquine. See, all these drugs, your leflunomide and your chloroquine and your methotrexate and your sulfasalin, all these drugs are coming under your disease-modifying rheumatoid arthritis drug. Right? These drugs are coming under the management. These are the drugs in the management of your rheumatoid arthritis, as you all know. Upon these drugs, you have to be very clear. Chloroquine, a derivative, that is your hydroxychloroquine. Hydroxychloroquine. This drug having the increased risk of causing corneal deposits. Corneal deposits. Right. On the other hand, they can also ask like old like appearance. Eye is old like appearance. Or it can also cause bull eye retinopathy. Bull eye retinopathy. And the most important thing you have to remember is corneal deposit. Obviously, we have clicked the answer. Chloroquine is the correct. And along with that, if they are going to ask you old like appearance or bull eye retinopathy, the answer will be your hydroxychloroquine. That is a component of your chloroquine. As you all know, chloroquine is also used as an anti-malarial drug, which you people know. Right. On the other hand, please remember, what is the other drugs which can cause corneal microdeposit? Microdeposit. Which other drug can cause corneal microdeposit? It is your important drug, that is your amiodarone. Amiodarone causes corneal microdeposit. Remember this thing. Amiodarone causes corneal microdeposit. So I would like to add a few words on other thing, like in previous question we had a word on insulin also. So shortest and fastest acting insulin. What is the shortest and fastest acting insulin? Shortest and fastest acting insulin. What is the shortest and fastest acting insulin? Yes, active students, please answer me. What is the shortest and fastest acting insulin? It is an inhalational insulin, as you all know, that is your Afreeza. Right, that is your Afreeza. That is administered in inhalation route. And the most important clinical point you have to remember is this Afreeza is having the property to increase the risk of which particular cancer? Obviously, inhalation, it is lung cancer. And remember, Afreeza is contraindicated in case of your asthma and COPD. Don't answer this. Asthma and COPD. Right? These things are very, very important to be remembered. So we will go to the next question. A patient present with fever, productive cough, and weight loss. He gives a history of not having completed treatment for tuberculosis thrice. So he is a reactivation case or a resistant case. To be very specific, we can tell he is a resistant case. And in the past, extensively drug-resistant TB is suspected. And they have given the diagnosis, it is an extensively drug-resistant TB. Right? Now, you people have to answer me clearly. How is this entitled? How this entity is defined? So when we are telling a patient is an XDR TB, extensive drug-resistant TB is XDR TB, right? So now tell me, in what case we are telling a patient is a case of extensive drug-resistant TB? Answer. Very good, Nadia. Please give a big round of applause to Nadia. Very good, Sanjita. Very good, Sugant. Very good, Ishika. Very good. So resistance to INH plus rifampicin plus olfloxacin plus linezolid. Even in spite of linezolid, if you're going to give bidaquilin also, you're going to take this as a correct answer. Right. How do we define this is a case of extensive drug-resistant TB? You have to remember resistance to your isoniazid, rifampicin, and one fluoroquinolone, that is your olfloxacin or your levofloxacin or your moxifloxacin, olfloxacin or levofloxacin or moxifloxacin. Plus along with that at least one additional group of drug, like at least and resistant to one additional group A drug, that is either your linezolid or your bidaquilin, right? So what you have to remember here is this is an extensive drug resistant TB, which is very clear for you people. So now tell me a NORCET centric important question which can come from moxifloxacin. Moxifloxacin is a drug which causes maximum QT prolongation. Among all the drugs which causes QT prolongation, moxifloxacin is a drug which causes maximal QT prolongation, That is also you have to remember, right? So extensive drug resistant TB, and we also have rifampicin resistant TB. So this is the definition for your extensive drug resistant TB, right? So next we'll go to the next question. A 28 years old HIV positive mother have recently given birth to her baby. She has never been receiving antiviral therapy during her pregnancy to manage HIV infection. She was not receiving any form of antiretroviral therapy during her pregnancy to manage her HIV infection. The mother expresses her intention to exclusive breastfeeding for her breastfeeding of her children, breastfeeding of her child. The healthcare provider discusses the appropriate care for the neonate in this scenario. Which of the following is an antiretroviral drug of choice to be administered to the baby? Obviously, many people have started answering correct. Very good, Sugant, Nadia, Sanjita, Shalini, Ishika, Lomi, Rupesh. Very good. So Rifampin is the correct answer. Whenever there is a question on prenatal transmission of HIV, the drug which we are giving for the neonate in order to prevent the prenatal transmission of your HIV, that is your Rifampin. Remember neonates N and your Rifampins N. Right? Zerobidin, your lamivudin, ritonavir, or the other drugs which is used in the management of your HIV. Right? So next question. Which drug can used to treat both HIV and hepatitis B? Which drug can be used in case of both HIV and your hepatitis B? Now give me the answer. The drug which is solving two purposes, both HIV as well as hepatitis B. Now I'm waiting for your answers. It is your nucleoside reverse transcriptase inhibitor drug. Yes, what is the correct answer? Yes. Yes, very good, very good. Very good, Shalini, Sugant, Sanjita, Nadia. Like I'm telling repeatedly these people name, and I hope these students or you people are the subscribers of Plan C English. I hope so. Like I wish you all a very best and hearty congratulations from the bottom of the heart. Like if you are on this speed, this is very good for your mains. This is a very good sign that you can possibly crack mains so easily, right? The correct answer is B, that is your tenofovir. Now, additional questions for you. Here where I play a role, right? Like how I will tell that, no, zidovudin is not the answer here. So tenofovir is a drug which can solve two purposes. That is, it is used in management of HIV and your hepatitis B. So now tell me the important thing. What is the side effect of your tenofovir? What is the side effect of your tenofovir, which can be commonly asked in examination? What is the side effect of tenofovir? Tenofovir can cause. Sanjita, you will definitely get, don't worry. This time, you people are clearing mains and you people have to definitely message me, right? If you're a subscriber of Plan C Plus, you can directly message me from the group, or else you can follow my page, Nursing with Priya Balan, on Instagram, and you can message me there. Right. Now coming back to the question. Now tell me, tenofovir, what is the side effect of tenofovir? Any answers? See, remember, tenofovir side effect is nephrotoxicity. Right. So important nursing implication is to monitor RFT. Right. And this particular tenofovir is contraindicated. Solving two purposes. If you are learning it, a side effect is nephrotoxicity. Again, this drug is going to cause renal failure. Right. So this drug is going to cause renal failure when it is not. No. Sugant, there is an approach for examination. So listen, it is not about learning and learning and learning. It is like when you sit in the exam hall for that 3 hours. Okay, Himan. See, when you sit in the exam hall for 3 hours, when you're sitting in the exam hall, generally I'm telling you, that time you should be very attentive in reading the question. Even simple words you can leave. For example, least effective, most potent, not potent, which of the following drug is not actually used in the management. So these type of questions are trap questions, right? What you need actually is a simple, calm mind. Okay, a simple, calm mind. And you should be believing in yourself that I have studied, I have put this much of hard work. So I definitely can clear this examination. Whatever question is going to come, I'm going to see it. I'm going to see a hand to it. Definitely, it is not going to come anything out of which I have studied. So whatever questions come, I'm going to handle it so carefully. So be very confident, be very calm, and be very attentive. Concentrate on the question. Always think about what is given in the question and what is the 4 option. First of all, if you can able to find the correct answer, it is well and good. If it is not possible, what you have to do? You have to follow the trick of rejecting the distractors. Definitely, this will not go with this. Octreotide will not go. Like HIV and hepatitis B, no, it is not possible. Like that, you have to reject the distractors as well. So for clearing mains, definitely the student who have well prepared, your target number of questions you have to attempt is 130 plus. Right? Among 9,000 students, if you want to come at the first 3,000 rank, it is very, very important. Like you have to at least attempt 130 plus MCQs. Plus, don't run that I have to definitely attempt 130 plus MCQs. It is not the case. You should be very clear in this concept as well. Like accuracy is very important than numbers, right? But for the questions which you people are like, you cannot reach the minimum level which you have to attempt. At that time, you have to take a calculative risk. And the recent trend of NORCET examination, if you talk about section 1 of your NORCET, previous NORCET examination, it is stating that the first section was really tough and tricky and more critical thinking or clinical based critical analysis based MCQs, where they want to confuse you and reduce your confidence level. So first section, just remember, there will be some strategy for them also to make you weak or to make you think about the first section after you go to the next sections also. Don't carry the stress of your first section or even the first MCQ to the second MCQ. Give your brain adequate time to process because everything you have studied. Be very calm there. Read the question so attentively. First, understand the question. Many students are telling me that I have problem in basic comprehension of the question. Basic comprehension will come only if you attentively read the question word by word. Right? Do that. Definitely success is yours. Believe in yourself. Definitely that is going to happen. Right? So coming back to tenofovir is contraindicated in renal failure patients. Right? So this is very, very important to note again. So next we will go to the next question. Ondansetron is prescribed for a patient experiencing. Thank you so much. Thank you so much, dear, and very all the best for everyone who is going to write your mains examination. This is a very, very life-changing career, as you all know. But remember, this is not a destiny. We have n number of examination which is going to come back. So carry that attitude so that you will have that reduced stress level and anxiety. Mostly practical-based MCQs are going to come. Think like a nurse. Don't create any advanced or unknown scenarios. Just because you studied more, you should not think advancedly. Whatever it is given in the question, I'm going to see it. Whatever it is given in the option, I'm going to see it. Based upon that, only my answers will be. I'm not going to create any form of scenarios. Right? Yes. Coming back to the question, ondansetron is prescribed for a patient experiencing chemotherapy-induced vomiting. Which is the nurse and what is the nurse understanding of how this drug works? Obviously, now only we have studied about ondansetron. Ondansetron is your 5-HT3 inhibitor, and this drug is having the effect to work centrally in your vomiting center. Now tell me what is the vomiting center? And peripherally by enhances the gastric emptying. It has two effects, right? It has two effects. It acts centrally by reducing the vomiting, and it also enhances gastric emptying. Right, this is very, very important point you have to tell. Now tell me. Yes, 5-HT3 center. Very good, very good, very good. Yes. So D is the correct answer. Next, we will go to the next question. What is the most appropriate nursing intervention for an elderly client using milk of magnesia to manage constipation? So what will be monitoring preference? Yes, very good, very good, very good. Now tell me the answer for 16th question. The most appropriate nursing intervention for an elderly client using milk of magnesia. As milk of magnesia is having an electrolyte name itself, so this drug has an increased risk of causing hypermagnesemia. So definitely monitoring the electrolytes, serum electrolytes will be the primary thing, specifically magnesium. Provide supplemental vitamin B and C, advise the client to reduce physical activity, suggest the use of inconsistent incontinence pad. No. Remember, it causes hypermagnesemia, so you have to monitor the electrolyte level. Very good, Bhupesh, Hulami, Sanjeet, Ishika, Anjana, Nadia, Shalini. Very good. Sugant. Yes. When managing a patient with cholecystitis, which prescribed medication should the nurse question? Here, what will you do when you are in the competitive examination, when you are so stressed? What medication is prescribed? You will be thinking. But they're asking which prescribed medication should the nurse question? See, that kind of halo will happen in the examination. Be very clear in this. Is again, students started answering correctly? Yes. Morphine is generally avoided in case of cholecystitis. Why? It is a very easy question because it causes spasm of your sphincter of Oddi, right? It causes spasm of your sphincter of Oddi, right? This may worsen and even complicate the bile flow. This may worsen or even complicate the bile flow. That's why we are not administering morphine in cholecystitis patient, right? So probanathin is an anticholinergic drug. Again, atropine is an anticholinergic drug. What about your compazine? Compamazine? Compazine is a anti-emetic drug. Yes, very good, very good, very good. So next question. What is the primary basis for initiating antibiotic treatment for pneumonia? This is our application-based question. What is the primary basis for initiating an antibiotic treatment for pneumonia? Now answer in the chat box. Yes. See, while talking about any patient with pneumonia, primarily the severity of the patient's symptoms, they're asking. No, based upon the severity of the patient's symptoms, we won't act, right? See, antibiotic therapy. Yes, 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 yes. Now many students started answering correctly. Follow me, Sugandh, Sanjita, Shalini. Very good. See, Sanjita, no. See, listen, the D is the correct answer. See, why? Practically think the gram strain or cultural sputum, it is going to take days for the result. Right? Do we wait until that? Initially, we will be starting with the basic antibiotics and start dose in order to stabilize the patient and in order to revert the patient. That will be the primary responsibility of us. Right? So, based then later, we will be sending the sample and we will be starting the empirical antibiotic therapy. But primarily, with history, physical examination, and chest X-ray findings, if the patient is diagnosed prominently as pneumonia, we have to start the antibiotic therapy. Right? Because this is going to worsen the symptoms. If you're going to wait for gram strain and culture of the sputum sample, it is going to take day and the treatment is going to delay. It is silly. It is a very silly question, right? And you make silly mistakes. So that is the important thing. This particular tactic only you need to understand while preparing for competitive examination, right? Be very clear that practically you just think simply, common sense. These are common sense. What I have to do in that particular situation? Do I start the antibiotic therapy for a pneumonia patient after 1 week after the culture results came? No, definitely not. With history, physical examination, and chest X-ray findings, I'm diagnosing, the physician is diagnosing, and the treatment is started immediately. Then, once the culture result, everything is coming, then the drug-specific therapy, drug-specific antibiotic therapy will be started, right? Now, let's go to the next question. A patient with upper gastrointestinal bleeding is receiving treatment with several medications. Which drug should the nurse identify as one to reduce bleeding and to suppress gastric acid secretion? Here they are asking about a dual role of a drug. The drug, okay, the drug which is going to cause reduced bleeding. So just gastrointestinal bleeding, upper gastrointestinal bleeding. So obviously, in order to reduce the bleeding, they are telling the case is a varicose bleeding, right? The case is a varicose bleeding. The case is a varicose bleeding. So many people started answering correct. Octreotide is a somatostatin analog. It's a somatostatin analog, which has a dual purpose of reducing the, as an important drug of choice in the management of varicose bleeding, as well as to suppress the gastric acid secretions, right? So this is a drug of choice. Again, now tell me classically, in what are the cases this octreotide is a drug of choice? Octreotide is a drug of choice for acromegaly. Octreotide is a drug of choice in case of acromegaly. It is a drug of choice in secretory diarrhea. It is a drug of choice in case of your glucagonoma or in case of your vipoma. What is meant by vipoma? In vipoma also this octreotide is an is a drug of choice. What is vipoma? Vasoactive intestinal peptide related abnormality related. It's a neuroendocrine tumor. Okay, in the pancreatic islet cell. Okay, in pancreatic islet cells, if we have any form of neuroendocrine tumor, yes, if you form any form of neuroendocrine tumor, in that case also, this is a drug of choice. Other use of this drug is your varicose bleeding, acute varicose bleeding, and in case of your thyrotrope adenoma also it is used. Thyrotrope adenoma. Okay. Now tell me what will be the side effect of this drug? What is the side effect of this drug? So in case of thyrotrope adenoma also this drug is given. In case of your pancreatic tumor also this drug is given. This drug can cause hypothyroidism as a side effect. Okay. Hypothyroidism. And it can also cause gallstones, cholelithiasis. It can also cause gallstones, that is cholelithiasis, right? Yes. Next, we will go to the next question. Which of the following is a long-acting muscarinic antagonist which is used once daily in COPD? Yes, a very, very testing question. Be very clear, which is a LAMA drug, that is your long-acting muscarinic antagonist, which is administered once daily. Yes, waiting for the answers. Yes, answers. That is also a drug of choice. Very good. Tiotropium is the correct answer. Now answer in the chat box. What are all the other drugs along with tiotropium is used in the management of your COPD and in asthma? So tiotropium is your primary drug of choice. Along with that, we also use your imiclinidium, your imiclinidium, and your revifenacin. These drugs are considered to be the long-acting muscarinic antagonist. Muscarinic antagonist. This is going to inhibit the M3 receptor, right? So what is the effect? It is going to cause bronchodilation. It's going to cause bronchodilation. Right. This is going to cause bronchodilation. So along with that, we have other drugs, that is your aclinidium, right? Other drugs includes your aclinidium and ipratropium. Ipratropium. Now, what is the important MCQ point you have to remember? As I said you, this is LAMA. This is long-acting muscarinic agonist, right? Your aclinidium is your intermittent acting muscarinic antagonist. This is administered in BD. This is administered in BD. Whereas these all three drugs, that is your tiotropium, imiclinidium, and your revifenacin are administered in OD That also you have to remember. Next, we also have ipratropium. Ipratropium is purely a short-acting beta antagonist. It is a short-acting beta antagonist. So the administration is QID. The administration is QID. So some students are talking about salbutamol. Be very clear, children. Under your muscarinic antagonist, these are all the drugs which is coming under your management of bronchial asthma and COPD. Right? Right. So when we talk about salbutamol, let's break salbutamol also. Right. So people are talking about salbutamol. So what is salbutamol? Salbutamol is a beta 2 agonist. Salbutamol is a beta 2 agonist drug. See, it is an antagonist drug. This is antagonist. This is agonist. Agonist means it increases the effect of beta 2 receptors. Antagonist means it is going to decline the effect of your muscarinic receptors, M3 receptors to be very specific, right? So beta 2 agonist, what beta 2 agonist is going to do? Beta 2 agonist is going to do bronchodilation again. Bronchodilation. So when we talk about the drug classification, this salbutamol, okay, your terbutaline, salbutamol, terbutaline, and your pirbuterol, okay, and your pirbuterol are coming under short-acting beta agonist, short-acting beta 2 agonist, right? Remember, short-acting beta 2 agonist or your salbutamol, terbutaline, and your pirbuterol, right? Now tell me, what are all the long-acting beta 2 agonists? The long-acting beta 2 agonist are your formoterol and your salmeterol. Formoterol and salmeterol are your long-acting beta 2 agonist. Long-acting beta 2 agonist. And again, we have another classification. This is the first classification, short-acting, second. And we have another classification of your beta 2 agonist drugs. What are they? We have very long-acting beta 2 agonist. Right. What are very long-acting beta 2 agonist? Any example drugs you can give? That is your olodaterol. Okay. Your olodaterol. Okay. And your vilanterol. Your vilanterol. Please give the answers. Vilanterol and your carmoterol. Right. So these drugs are coming under very long-acting beta 2 agonist drugs. These drugs are coming under very long-acting beta 2 agonist drugs. So what you have to remember here, I'll tell you an additional important point which you people have to remember. So if you talk about the beta 2 agonist drug, very good, Sugandh. If you talk about beta 2 agonist drug, remember beta 2 agonist drug are solving two conditions again, like your muscarinic antagonist drug. We also have beta 2 agonist drug is also going to act on your bronchial asthma and COPD. But here, please remember one important thing. Here, the muscarinic antagonist, every drug is used in the management of your asthma and COPD. But here there is a restriction. Only your SABA and your LABA, your short-acting beta-2 agonist and your long-acting beta-2 agonist is used in both the case of bronchial asthma and COPD. Right. On the other hand, when you talk about this very long-acting beta-2 agonist, they are only used in case of COPD. Why in case of asthma they need very long-acting beta-2 agonist? COPD is a chronic condition which needs chronic management, right? So that's why very long-acting beta 2 agonist are used in case of COPD only, right? And again, the additional important point you people have to remember is, in case the patient is taking beta 2 agonist, what is the important side effect? What is the important side effect? Any answers in the chat box? What is the important side effects the patient can go if the patient is a case who is taking beta-2 agonist? Yes. Active students? Active students? See, remember the important side effects of your beta-2 agonist is hyperglycemia. Very, very important. Hyperglycemia. These are basic things which you have to definitely remember before going for examination. Hyperglycemia. So what is the most common combination which is fast acting is SABA plus formoterol is used for fast acting to relieve asthma in fast and rapid. That's where you use SABA plus your formoterol. One short acting and a long acting drug. Right? So this is very clear. Yes. So now we are clear. Aclidinum again. Aclidinum is a intermittent acting muscarinic antagonist. Ipratropium is a short acting muscarinic antagonist. Salbutamol is a short acting beta 2 agonist. Short acting beta 2 agonist. So this is the difference you people have to remember. Right? And remember your tiotropium, imiclidinum, and your rifampin are administered only in OD, and they are long-acting muscarinic antagonist. And your aclidinum, that is your intermittent acting muscarinic agonist, which is administered only in BD. Ipratropium is administered in QID, that is a short-acting muscarinic antagonist. See, muscarinic antagonist, right? It is not, it is a error. Okay, it is a muscarinic antagonist. Right? Remember this thing, this is very, very important. Right? Yes. Tremors, palpitation, tachycardia. See, the classical side effect which you have to definitely remember is hyperglycemia. When hyperglycemia is given in the option, you have to definitely choose hyperglycemia. Next, we will go to the next question. The maximum dose of atropine given in case of bradycardia. It's a very, very easy question. I hope everyone will answer so appropriately. The maximum dose of atropine can be given in bradycardia. Yes. Give me the answer. What is the maximum dose of atropine which is given in bradycardia? As you all know, in case of bradycardia, the maximum dose which we give is 3 mg. What is the regimen? Initially, you will give 1 mg. After 3 to 5 minutes, you will give another 1 mg. And after 3 to 5 minutes, you will watch if the bradycardia is not revert, you will give another 1 mg. So total 3 mg only you have to give, not more than that. And the most important thing you have to remember is we have learnt about bradycardia and we have learnt about atropine is a drug of choice. We are very clear in that. But remember, atropine, when it is administered less than 0.5 mg, it causes serious effect, right? It causes serious effect. It causes paradoxical bradycardia. Okay, it will further even worse the bradycardia when you're going to administer atropine at less than 0.5 mg. Right? This is also a very, 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 very important point which you have to note. Right? Next, we'll go to the next question. Anticholinergic side effect. Which of the following is an anticholinergic side effect? Answer me in the chat box. Which of the following is an anticholinergic side effect? Yes. Which of the following is an anticholinergic side effects? It is a very, very easy question. Waiting for your answers. Which of the following is an anticholinergic side effect? Yes. Obviously, A is the correct answer. Dryness is the correct answer. Along with that, what are all the anticholinergic side effects we have? We have mydriasis. We have dry mouth. We have dry mouth. Very good, very good. Many students have answered correctly. Shalini, Sugant, Ankur, Bhupesh, Sanjita, Nadia, Savita, Joy. I feel so proud of you people. Okay, dry mouth, urine retention. Okay, urine retention or even constipation. Okay, constipation, tachycardia, and hyperthermia. Hyperthermia and again dry skin, which is already listed in the options. Sweating, salivation, increased GIT or cholinergic effects. They are cholinergic effects. See, anticholinergic and cholinergic, that's how you have to study so that you can remember it so easily. Next, we will go to the next question. What is the drug of choice for a long-term treatment of supraventricular tachycardia in patients with COPD and asthma? Which means they are talking about chronic SVT. What is the management of chronic SVT? Yes. Beta blocker, which is a rate controller. Rate controller drug, but it has a serious side effect of causing bronchoconstriction. Digoxin. No. Adenosine is given in case of acute SVT. And this is which is the shortest acting. Shortest and rapid acting is your adenosine. Again, Verampamil. Verampamil, calcium channel blocker, Verampamil and your diltiazem. Okay, very good. Very good. D is the correct answer. Diltiazem. These are calcium channel blockers, which are the rate controllers as well, which are the drug of choice in case of your COPD and asthma. If the patient is a case of COPD and asthma, where the following above drugs are contraindicated, this drug will be administered. Okay, so that is a very, very important point you people have to remember. Beta blockers, adenosine, these are contraindicated in patients with COPD and asthma because it can cause bronchoconstriction. Right? In acute attack, adenosine is the important management that you have to remember. Right? Yes. So next, which of the following is a standard drug regimen for managing chronic heart failure? Now tell me, which of the following is a standard drug regimen for managing chronic heart failure? For managing a chronic heart failure patient, you should do a fantastic effect or a fabulous effect, we can remember. So remember about the mnemonic FAB, that is F stands for your fusimide, A stands for either your AC inhibitors or angiotensin receptor blockers, and B stands for your beta blockers. No, digoxin, fusimide, calcium channel blockers. Calcium channel blockers are in case contraindicated. Calcium channel blockers are in case contraindicated in case of your chronic heart failure. Again, this is not the answer and this is not the answer, right? Okay. Next, we'll go to the next question. In patients with moderate to severe hypertriglyceridemia, which means the triglyceride level is high, which is 500 to 999 ng per dl, which medication is recommended as a treatment of this option? Now tell me classically, what is the answer? Again, this is a tactical question which you people have to answer. Very good. Fibrates is used when there is an increase in triglyceride level. Right. Statins are given in order to reduce the low density lipoprotein. Always be very clear in this. Statins are given in order to reduce only the low density lipoproteins, whereas fibrates are given in case of increased triglycerides in order to reduce the triglyceride level. Remember this thing. Statins you should not confuse here. Triglyceride, everything is a fat component. Triglyceride, your low density lipoprotein, everything is a fat component, but you should be very clear. When the triglyceride level is higher, the fibrates are the drug of choice. So examples of your fibrates are your clofibrate, your fenofibrate, and bezafibrate, and your gemfibrozil, right? These drug, what they do, it reduce the triglyceride, it reduce your very low density lipoprotein as well. But statins specifically act on reducing the low density lipoprotein, but fibrates are very dominant in reducing the triglyceride level. Very good, Ankur. Very good. So cholelithiasis is one of the important side effects. Gallstone is the one of the important side effects of your fibrates. Along with gallstones, what is the other side effect? That is your myopathy. That also you people have to remember. Very good, Ankur. Please give a big round of applause to him. Fibrates causes the side effects of gallstone. Along with that, it also causes myopathy. All right. Next, we will go to the next question. What is the drug of choice for managing epilepsy in pregnant women? Yes, an easy and important question. What is the drug of choice in managing epilepsy in pregnant women? The answer is your yes. Very good. Very good. Yes. Come on, tell me the answer. No. Very good, Ankur. Very good, Sugant. Very good. Your answer is levetiracetam. Levetiracetam is the drug of choice in the management of your epilepsy seizures in pregnant women. This is the least teratogenic drug. On the other hand, which is the most teratogenic drug? That is your valproate, most teratogenic drug. Right? On the other hand, lamotrigine is also used, but levetiracetam is the drug of choice. This valproate causes teratogenicity and it causes neural tube defects, as you all know, very, very common point. Right? Remember, if the patient is on valproate therapy, okay, if the patient is on valproate therapy, we have two conditions. One, the pregnant woman is pregnant. On the other hand, she is planning for pregnancy. Right? So when she is on valproate therapy, we have to continue the valproate therapy. Right? And what do we have to do? We have to do a drug monitoring that is termed as your therapeutic drug monitoring. And what we have to do? We have to give folic acid to this particular patient in order to prevent the neural tube defects. But here where the MCQ comes. Folic acid if you are giving, when the patient is having a history of neural tube defect in previous pregnancy, then you are going to prescribe 4,000 mcg of folic acid in order to prevent the neural tube defect. When there is no history of, on the other hand, when there is no history of neural tube defect, then I'm going to give only 400 mcg. Right? Very good. Right? This is very important. When coming to the planning pregnancy, okay, we have to have a drug-free interval, and we have to give a drug-free interval. Like we should not administer valproate at that time, known case of seizure, right? So if seizure is there, we are leaving as such. If seizure is present, then what we are doing, we are going to administer your levetiracetam, right? Then you're going to administer your levetiracetam, right? This is again very, very important point you have to note. Very good. Like remember the folic acid dosage which you have to give if the patient is having the history of neural tube defects, or if he is having no history of neural tube defects, right? So next, in case of status epilepticus, which medication is preferred? In case of status epilepticus, which medication is preferred for the treatment? Now tell me. For a patient with status epilepticus, which treatment is preferred? Answers in the chat box. B. Joy BB, Sugandh, Fire, everything. Very good. See, lorazepam is the drug of choice in case of your status epilepticus. Okay, lorazepam is a drug of choice in case of your status epilepticus. Along with status epilepticus, in case of alcohol withdrawal, in case of your alcohol withdrawal, also your lorazepam is the drug of choice, which means your lorazepam is the drug of choice. Arrow has gone quite low. Let me correct it. Right? Drug of choice in case of status epilepticus as well as alcohol withdrawal symptom, it is lorazepam. Now tell me, valproate we have. Valproate is a drug of choice in what are all the cases? Valproate is a drug of choice in what are all the cases? Good evening, Sangeeta. Good evening. Good evening, dear. Yes. Lorazepam followed by phenytoin infusion for maintenance. Very good, very good, very good, dear. Very good. Very good, very good. Valproate is a drug of choice in case of your generalized tonic-clonic seizure, your myoclonic seizure, right? In case of your mixed seizure syndrome, that is your LGS. What is LGS? That is your Lennox-Gastaut syndrome. And in case of your Dravet syndrome also, valproate is a drug of choice. So these things you have to definitely remember, right? In case of absence seizure, what is the drug of choice? Absence seizure, what is the drug of choice? Answer in the chat box. What absence seizure, what is the drug of choice? Answer in the chat box. In case of absence seizure, what is the drug of choice? Remember ethoxyzimide. Okay, your ethoxyzimide is a drug of choice in case of absence seizure. Alternative drug is again valproate. Alternative drug is valproate. In case of partial seizure, or in case of your Rolandic epilepsy, the drug of choice is carbamazepine. Right? In case of infantile spasm with tuberous sclerosis, in case of infantile spasm with tuberous sclerosis, in that case, what is the drug of choice? That is your vigabatrin. This is again very, very important to be remembered. In case of infantile spasm infantile spasm without tuberous sclerosis, then what is the answer? Very good, very good. Fire and edge. Very good. You are on fire. In case of infantile spasm without tuberous sclerosis, otherwise known as West syndrome, here the drug of choice is your ACTH. Here the drug of choice is your ACTH. Again, an additional point which I would like to add is, in case of seizure in neonates, neonatal seizure, what is the drug of choice? Answer in the chat box. What is the drug of choice in case of neonatal seizure? In case of neonatal seizure, it is your phenobarbital. It's your phenobarbital. Right? So these are the very, very important MCQs which you have to definitely study. Very good, Ankur. Very good. Very good. Ankur is on fire again. It's very good. So with the same fire, you have to go in your mains, clear your mains immediately and come back to me again, right? So that's how these are the important points you have to remember. Okay. So remember, lorazepam is a drug of choice in case of status epilepticus and as well as in your case of your alcohol withdrawal syndrome. And valproate is a drug of choice in case of your generalized tonic-clonic seizure, myoclonic seizure, and your Lennox-Gastaut syndrome and your Dravet syndrome. In case of absence seizure, ethoxyximide, an alternative drug is valproate, is the drug of choice. And in case of partial seizure and your Rolandic seizure, Rolandic epilepsy, carbamazepine is a drug of choice. In case of infantile spasm with tuberous sclerosis, your vigabatrin is a drug of choice. Infantile spasm without tuberous sclerosis, your ACTH is a drug of choice. In case of neonatal seizure, phenobarbital is a drug of choice. Right? This is very, very important to be noted. Next question. What is the first line treatment of infantile spasm associated with tuberous sclerosis? Just now we have studied. Just now we have studied this. I want the answers. Just now, before a second only, we have discussed about it. Very good, Sugandh. Phenobarbital is a drug of choice in case of your seizure in neonates. Now, infantile spasm associated with tuberous sclerosis. Obviously, vigabatrin. Never ever do mistake in these things, right? Because these questions are very commonly asked in examination, right? Next, we will go to the next question. Which of the following condition is best treated with your amiloride as a drug of choice? Again, to test your intellectual capacity, one important question which is coming in the last. Which of the following condition is the best treated with amiloride as a drug of choice? First of all, what is amiloride? Very good. Ankur on fire. Lithium-induced nephrogenic diabetes insipidus, the drug of choice is your amiloride. Amiloride is your potassium-sparing diuretic. It is your potassium-sparing diuretic drug. So this potassium-sparing diuretic amiloride specifically acts on your ENAC receptor. Okay, ENAC channel, sorry, your endothelin sodium channel. And it prevents the entry of lithium via the principal cell. This is the principal cell. So this amiloride, what it will do, it prevent the entry of lithium. Entry of lithium via this ENAC channel, that is your endothelin sodium channel, which is a principal channel where the lithium will be getting entering and it causes lithium-induced diabetes insipidus. Diabetes nephrogenic, lithium-induced nephrogenic diabetes insipidus, which means there is a less amount of ADH, as you all know. And this amiloride is also a drug of choice in case of your Liddle's syndrome. So now we have studied amiloride is a drug of choice in case of your lithium-induced nephrogenic diabetes insipidus. So syndrome of inappropriate SIADH, what are all the drugs we will be giving? In SIADH, the most important point you people have to remember, SIADH drug of choice or Vaptans. Vaptans are given in the management of SIADH. SIADH is a condition where there is an increase in ADH, as you all know, antidiuretic hormone. So the drug of choice is Vaptans. Example is your tolvaptans. Yes, any answers? Tolvaptan, conivaptan. These are the example of Vaptan drugs, right? Again, in Cons disease, what is Cons disease? Excessive aldosterone secretion. If aldosterone is high, what is going to have? Aldosterone. What aldosterone do? Aldosterone causes sodium and water retention. Whereas, on the other hand, potassium and hydrogen excretion. Right. In Crohn's disease, the primary hyperaldosteronism, right, in the tumor, there will be excessive aldosterone, which is going to cause excessive accumulation of sodium and water and excessive excretion of potassium and hydrogen. So the management is your spironolactone. Here, in case of Crohn's disease, I'm writing in a different color. In case of Crohn's disease, the drug of choice is spironolactone. Right. And your eplerenone also we can give. Next, we have Batter syndrome. Here, Batter syndrome. Here, we are going to administer indomethacin and potassium supplements only. Here, amyloid is not a drug of choice, right? Yes. The last question of the day. Manish, a patient of hypothyroidism, was prescribed thyroxine. Hypothyroidism patient prescribed with thyroxine. Which of the following is the most reliable guide for adjusting of the thyroxine dose? Yes. As you all know, TSH level is elevated in case of hypothyroidism because of the feedback inhibition, right? So administration of thyroid hormones such as T3 and T4 decreases TSH by contributing the feedback inhibition, right? So here the TSH level has to be monitored in order to adjust the level of dosage. For the first 3 months, we will be having a regular monitoring of the TSH level in order to adjust the dose accordingly, right? So this is the answer for it. Very good, Ankur. Ankur has answered it very correctly. So here we have came to the last point of the session, and the session is ending here. And I hope this session was really useful for each and everyone who were watching it with me. And the special students includes my my dear children, that is Sugandh, Sanjita, Ankur, Bhupesh, Joy. They are very studious. I hope you people should definitely. Anjana, also Shalini, Nadia, Fire and Edge. Very good. These students are very active during the chat. So I hope all the very best for your examination, mains examination. I hope I have given a good insight on this pharmacology class. So all the very best. If you have any doubts, you can do check out my page, Nursing with Priya Balan. Any form of scientific queries, doubts will be answered there. My Instagram page. Okay. So any form, any kind of scientific queries which is related to adult health nursing or pharmacology, you can answer me direct. You can ask me directly. I'll be answering you. So This is all about today. And thanks for watching. Thank you so much for all the new learning. Very good. See, if I'm telling some new things, you should be also a new learner. Came by chance, but stayed by choice. Very good. Okay. Very good dialogue. Yeah. Fire and H. That's good. See, if I'm telling new information also, you should have that grasping capacity to learn it. Again, do rewatch the video if you want, and it will be very helpful. We have all the previous important live sessions also, which have been taken. You can also refer those videos also. Thanks for watching. All the very best for your AIMS examination. Thank you.